privileged to introduce Dr. Surveen. She's Dr. Professor Surveen Ghumman. She's a Senior Director and HOD of Infertility and IVF Center at Max Panchi. She has got a good 32 years of clinical experience. She has authored 9 books, out of them 2 are published internationally, and she has more than 80 publications in her credit. She is a secretary of Indian Fertility Society. She has got many crowns in her to be mentioned.
She has got many jewels in her crown.
Yes, and there are lots. She has got many awards in her credit, and now she will guide us to approach a patient, how to approach a patient regarding fertility.
I give you a good news. India has just won the first ODI. And some of you who might have think that we must have defeated New Zealand by more than 200 runs. New Zealand actually got very close to us. 340 runs they got in the end. We just barely managed it. And on that good note, I assume that all of you will give your full attention to Dr. Surveen. She only asked me to announce this so that you don't keep asking your friends, यार वो स्कोर क्या हुआ? यार स्कोर देख ले. इंडिया जीत गया. अब चुपचाप सुनो.
My time starts now. Okay, good evening everybody. It's a pleasure to be here and thank you for inviting us. Many people feel infertility, oh, that's the gynecologist. No, infertility is first the physician, first the surgeon. The infertile male is going to walk into your offices. The man with the varicocele is going to walk into your offices. The girl who is not getting married till 35 is going to walk into your office. You need to tell her to go and freeze eggs. The cancer patient is walking into your offices. You need to tell her to get oncofertility. A HIV positive male is going to walk into your office. He needs an ART to get a child. So it is very much your topic. We need to identify what are the indications to ensure that the right treatment is given at the right time, to start the treatment and to stop the treatment, and when to refer these patients. So basically, if somebody with a very prolonged infertility is walking into your office, they need an infertility person. Somebody who is old, 40 years, not conceiving, you need to send them immediately. Somebody who has pelvic factors, endometriosis, tubal factor, combined factors, appendicitis, maybe intestinal tuberculosis, woman not conceiving, you need to send her. What about making decisions in tubal factor infertility? She's come to you maybe with a tubal block. History of tuberculosis, she is not going to conceive, no surgery. Tubal ligation, yes, you can try. Very extensive peritubal adhesions, again, not going to conceive, you need at least 4 centimeters of length to repair that tube. You need to look into other associated factors of infertility before you make that decision. She is very old, she doesn't have any eggs. Don't take her up for a tubal surgery. It's not going to work. She has a hydrosalpinx. Again, hydrosalpinx is something which is not going to make her conceive because it prevents implantation. So she basically needs a salpingectomy. All these patients with extensive tubal damage, hydrosalpinx, you need to think IVF and you need to take the decision before taking her up for anything. It could be intestinal obstructions with the hydrosalpinx. You need to tell her that I might be clipping your 2 tubes along with doing my surgery because that's what's good for you. Unexplained infertility, ovarian dysfunction, yes, that's the gynecologist. So basically 3 to 6 cycles of ovulation induction, and if that does not succeed, the 5th IUI is going to give you very poor results. Kindly send for IVF. Endometriosis with any other surgical problem, well, endometriosis always gives a poor result. If it's mild, you can take her up for minimal treatment. If it is severe, you need to really tell her that, look, this is the result which you're going to get. It's a 50% compared to somebody who doesn't have endometriosis. What about the male factor? That's something which is going to concern all of you. There's a male who's coming into your office and he has a low sperm count. 15 million is the cutoff. But actually, it's not just 15 million. You have to take into account the motility, the total inseminating motile count, and that is the count multiplied by the percentage motility multiplied by the volume, and then you take your decision on whether he is fertile or whether he needs to go to a fertility center. Not only the count, you need to look at the morphology. If the morphology of the sperm, and many of the semen analysis which come to you don't even have a morphology done. The count could be totally okay, but if the morphology is poor, then the pregnancy rate is just 4%. You need to send her. But you tell me, I don't want to do this maths, I don't want to be calculating the total inseminating motile count. Tell me how to decide on a semen count. Well, total count of more than 10 million, actively motile more than 40%, total motile count which I told you more than 5 million, and morphology more than 4%. You really don't need to send them to a fertility person. They can be well treated in your OPD chamber. So science really advanced with ICSI. When an oligospermic male came to us, we started actually picking up the sperm and injecting it in the egg because the sperm was not strong enough. And when an azoospermic male came to us, we managed to take out sperm from the testes, do the fertilization and give them the baby. So came testicular aspiration and testicular biopsy. But beyond that came micro-teaser. Micro-teaser is not done in many centers. You need a microscope, operating microscope next to another OT, next to the IVF lab. We at Max do have it, and what is done in micro-teaser is that you open up the testes, you look for dilated vesicles and you pick them up and milk them for the sperms. This is for azoospermic sperms. Advantages: minimal tissue removal and higher chances of sperm retrieval. Fertility preservation. Dr. Chulka is there, and we fertility preservation program. Most of the cancer patients, after going chemotherapy, their egg reserves fall rapidly. So they do not have eggs. So before they undergo the chemotherapy, Dr. Chulka sends the patient to us. We preserve the eggs or the embryos if the girl is married, and subsequently after the treatment, we can give her a child. We've had breast cancer patients, they've delivered. Dr. Chulka is here to tell you that they've had babies post-chemotherapy. We've had testicular tumors and the man has had a baby after the surgery. Also social reasons, delayed marriages. I think this is a huge problem occurring in India. Women coming at 35, haven't found partners. There are women who are married, don't want to have children because careers. And I'm getting a huge sector of patients in this, and maybe you would be getting them in your OPDs. So we are doing social egg freezing. My niece is coming to get her eggs frozen from me, so it's very much in the family. But remember, if they come into your office and you're telling them to freeze eggs, freezing eggs is not equal to pregnancy, because every egg in IVF is not going to yield you a pregnancy. You need to tell them that there is a success rate to all this. How many eggs should I freeze? Well, it really depends upon the age of the woman. If she is old, even 20 or less. And if she is young, then 20 is enough to give you 2 pregnancies. Well, this is what was earlier said, but now we are commonly going in for egg freezing. Third party reproduction, I'm finishing in 2 minutes.
2 minutes, yeah.
2 minutes. Third party reproduction, donor eggs, donor sperms, surrogates. Well, we've got laws for all these. And one law says that only one donor to donate to one patient, so that this is not the scene we see, that you're sitting next to your half brothers and sisters because so many sperms were donated. Then low ovarian reserve. AMH is very low. This is something you could see coming in. Women who are older, they would require donor eggs. So you need to know that the AMH cutoff value is 1, less than 1. So donor cycles would be for women with premature ovarian failure, repeated poor response, repeated negative IVF cycles, to avoid X-linked genetic diseases, very much so in your practices. And an Rh negative pregnancy, which is isoimmunized. Surrogacy, where pregnancy is contraindicated, the uterus is destroyed beyond, beyond its bearing, and poor endometrium with repeated implantation failure and recurrent pregnancy loss. Lastly, the pre-implantation genetic diagnosis. You have a patient who has a child who is thalassemic. You need to tell that patient that please go get an IVF done, get an embryo biopsy done so that your next child is not thalassemia major. So this is where IVF counts in your practices. One of the patients is affected by cystic fibrosis. You need to check that embryo. Recurrent pregnancy loss, maybe there is a genetic component to it. The embryo needs to be checked. Older women, 80% eggs are abnormal, can lead to downs. They need their embryos checked. Lastly, infectious disease. HIV, hepatitis B, hepatitis C. While achieving pregnancy, the partner can infect. So, an ART, assisted reproductive technique, is needed to wash the semen and make sure no viral particle is attached, and we do an IVF with it. To summarize, indications: male factor infertility, absent damaged tubes, endometriosis, unexplained infertility, which is just not conceiving, recurrent intrauterine insemination failure, adhesions, poor ovarian reserve, pre-implantation genetic diagnosis, premature menopause, and uterine pathology. We at Max have a pregnancy rate of 50 to 65%, a cryo survival of 100% because of a full-time trained embryology team, strict quality control which Max is known for, internal and external audits, internationally trained clinicians and global protocols, and the best equipment. The test of our progress is not whether we add more to the abundance of those who have. It is whether we provide enough for those who have too little, for those who have no children. So we should refer for IVF with a cost-benefit analysis, but is there a cost to the baby? Is there a cost to the time lost? Is there a cost to the stress of the couple? So you really cannot do a cost-benefit analysis. So recognize clinical situations where IVF is more successful and cost-effective, and you should know when to stop your basic treatment and move on to IVF. The hardest choices in life aren't between what is right and what is wrong, but between what is right and what is the best. So IUI or tubal surgery or IVF may be right, but is it the best option? There is a thin line between a good infertility expert and an excellent one, and that actually depends on the choices made. Are they right, or are they right in the best? Our practices are Hippocrates, do no harm, and the Cochrane, evidence-based medicine. And what we all want is this: a beautiful result. Conception may have moved into the laboratory, but nature still has a big hand to play. Thank you.
Great talk, ma'am. Dr. Surveen, last talk. You have a question? Yeah, come here. Dr. Sushruth will ask a question.
So ma'am, many of us as a age group, we have daughters and daughters-in-law in 30 plus age group, and issue may be primary or secondary infertility. So is there an approach to a art and IVF primary versus secondary infertility? This is one question. The second is what COVID has done to infertility of male and female?
Very interesting question, the second one. So primary and secondary infertility, no. I don't say there's a different approach, because the woman may be wanting the second child as much as the first child, and the causes could be the same. But yes, in a second child she'll be older, her eggs will be of a lesser quality, so you need to act fast. If it's a secondary infertility, don't sit on it. I think it should be done fast. Post-COVID, very interesting. I have had so many low AMH patients coming in, decreased ovarian reserve, and I have asked them one single question: did you get COVID recently? And it's a yes. So, and it's like a full epidemic of women with low egg reserve coming to us, and I don't know why that has occurred, but I can only relate it to COVID because this has happened post-COVID. At the moment, there are not many studies, but studies are coming up.
Male fertility.
Male fertility, I have not seen so much, but yes, COVID it has been found in the semen of men infected. And hence, what we are still doing is we are testing men and women before we take them up for procedures, before any semen enters our lab, because we could be freezing COVID with the liquid nitrogen along with the semen. So we are very, very careful, and we could probably at a later date cause an epidemic of COVID when we thaw that semen.